Yes, sir is there.
Doctor, we are live now, doctor.
Hello and welcome everyone for today's presidential live webinar masterclass series. Today we have two wonderful past presidents of Glaucoma Society of India, Dr. Devindra Sood from New Delhi and Dr. B.K. Nayak from Mumbai. Let me take this opportunity to introduce my good friend, Dr. Devindra Sood. He is a consultant at Max Eye Care, Panchil Park, New Delhi. He has done his postgraduate ophthalmic training from Maulana Azad Medical College, New Delhi. Did his tutorship in ophthalmology at Arvind Eye Hospital, Madurai. Did his fellowship at LVPI, Hyderabad, and also at Glaucoma Imaging Center at New Delhi. And to name a few of his professional achievement, I know Devan has done more than this, what I'm going to tell now. He has received many of the Oration awards at different places in India, namely Noel Moniz Memorial Lecture at Cochin, Professor A.N. Pandya Oration at Bihar, Dr. Mohanlal Oration at Aligarh University, Aligarh Ophthalmic Society. Then he has received Uttarakhand State Ophthalmic Association's UK SOS Gold Medal for Excellence in Ophthalmology, Major SC Dutt Oration from West Bengal in 2010, and of course many more. Dr. Devindra Sood has presented and published many articles, and he has been one of the best tutors or lecturers and gives a wonderful talks in various podiums in India, not only in India, across the globe. Without much delay, may I request Dr. Devindra Sood, our past president, to give his first talk for next 20 minutes. Over to you, Devin.
Thank you, Dr. Satyan. It's actually a pleasure and a privilege. Is my slide visible?
Yes, Devin.
Okay.
Yes.
I'd like to thank the Glaucoma Society of India, Dr. Satyan, President, Dr. Manisha, and Dr. Devin for this opportunity. Hippocrates first described glaucoma, and since then, technological advancements are constantly driving our definition, our concepts of glaucoma diagnosis and management. The definition of glaucoma actually depends on the perspective of the definer. To a scientist, it's about retinal ganglion cells, cell death because of many factors. To us ophthalmologists, it's about structural damage to the optic nerve with a correlating visual field change, irrespective of the level of the intraocular pressure. And to the patient, it's about blindness despite treatment. The current definition of glaucoma says that it's an optic neuropathy with a specific pattern of optic nerve and retinal nerve fiber layer changes. So let me put it differently and say glaucoma is a chronic progressive optic neuropathy, asymmetrical in presentation, and the aim of treatment is to prevent further deterioration and maintain the patient's vision-related quality of life. This decade is seeing the emergence of newer technology in glaucoma. But believe me, glaucoma as a disease has not changed. Technology only allows us to look at it differently, and our true focus should not be lost in the technology. As clinicians, we focus on the appropriate application of treatment, considering the potential of good versus possible harm from any clinical intervention to improve the health of the person as a whole. Damage from glaucoma is irreversible. So the key to maintaining the patient's vision-related quality of life is early diagnosis. And therefore, early appropriate treatment needs to be started early on so that further damage can be prevented. However, identifying progression in glaucoma is easier said than done. So primary glaucoma, so the goal of treatment in glaucoma can be redefined as prevention of progression of the glaucoma to a stage where it will affect the patient's vision-related quality of life. Now we know that with treatment, most eyes will not progress, at least not at a rate which will affect the patient's vision-related quality of life. But despite treatment, some eyes will deteriorate even under clinical care. The cumulative probability of glaucoma-related blindness is 27% in one eye and 10% in both eyes with a 20-year follow-up. There cannot be and will not be a consensus as to what progression in glaucoma means. And therefore, we rely usually on clinical trials to tell us about progression. Standard white-on-white perimetry is used to assess functional progression, and most studies depend on these photographs to document structural progression. The OATS and the EGPS showed that structural and functional changes seldom coincide in patients converting from ocular hypertension to glaucoma. Other studies have shown that the visual field changes may precede the development of optic disc changes. And then there's the clinician's perspective. This is a case profile of one of our patients, a 19-year-old with steroid-induced glaucoma. At diagnosis, he had a cup disc ratio of 0.7 in one eye and total cupping in the other. By the time he was 48 years old, he'd undergone glaucoma surgery in both eyes. There was total cupping, but he was managing well and was able to drive. By the time he reached 56 years of age, he was not able to drive and was having difficulty in reading. And the same patient, when he was 62 years of age, vision was stable, intraocular pressure less than 13 millimeters on repeated diurnals on a single drug, had now started developing visual hallucinations. This worsening of the visual comfort is progression. Similarly, another patient diagnosed to have glaucoma in 2005, when we saw him, the discs were normal, the fields was normal, and his intraocular pressure was controlled with a single drug for quite some time. And then by 2013, he required 2 drugs. By 2016, though the pressures were less than 21 millimeters of mercury, disc and fields were normal, he required 4 drugs for control of intraocular pressure. This increasing need for medication to contain the intraocular pressure is progression. This is a patient with an essential iris atrophy. We followed up over a period of time. From 2007 to 2018, there was a gradual progressive increase in the iris changes, which you can see over all these years. This is progression. Similarly, on gonioscopy, we can visualize the ciliary body band very easily. There's an adequate entry in 2005. Over a period of time, this gentleman started developing fluctuations in his intraocular pressure. Gonioscopy showed ciliary body band visualized, but there was a patchy pigmentation on Schwalbe's line, suggesting closure of the angle intermittently. And when the beam width was narrowed, there was a demonstrable closure which was happening. So this patient had progressed from open angle glaucoma to angle closure. Another patient in 2016, June, had a rubeotic front in the superior angle, refused any form of treatment, came back in November of the same year with a continuously raised intraocular pressure, and gonioscopy revealed gross crisscrossing of the rubeotic vessels. This is progression. Now, evaluation of the optic nerve is also an essential part, not just for diagnosis, but also to assess worsening over time. Simultaneous disc photography as split frame images are always preferred over sequential photography. But with the change in technology and the advent of digital photography, more and more monoscopic pictures are being taken and they are being viewed stereoscopically. Now, what we see here is an increase in the cup disc ratio, which is the most commonly used parameter, but it always needs to be seen in the context of the size of the disc. Here, if you see the supratemporal part of the left optic disc, observe 2007, 2008, 9, and 10, there's a significant narrowing which is happening associated with a change in the contour of the vessel. This is progression of the glaucoma status. Say again, this is the left eye of a patient in 2009, adequate superior neural rim. By the time it was 2014, there was a notch reduction in the neural rim width. And at that time, there was also a disc hemorrhage, which was progression. So this is progression. 2004, another patient, right eye, normal disc, normal fields. Saw him in 2005, there was a disc hemorrhage. Again in 2006, the hemorrhage had absorbed and was replaced by a nerve fiber layer change, and there were demonstrable, reproducible, correlating visual field effects only in 2007. Another patient, 2012, right eye, there is a pre-existing superior nerve fiber layer change. By the time it was 2015, there was an additional development of a new nerve fiber layer change inferiorly. Another patient, right eye, you can see a superior and an inferior nerve fiber layer change. Couple of years later, the inferior nerve fiber layer changed had widened as based on the vascular landmarks. This patient, right eye, 2007, the inferior rim is reduced in width. 2010, there was a hemorrhage. In fact, the hemorrhage mimics the positioning of the blood vessel and would often be missed. So actually, this patient in 2007 developed a hemorrhage in 2020. The hemorrhage was absorbed over a period of time and replaced initially by a small nerve fiber layer change, which widened by 2016. So all this is progression. Another patient, left eye, you can see the nerve fiber layer change inferiorly. There's a superadded disc hemorrhage, gets absorbed, and a nerve fiber layer defect, which is wider than what we had in 2011. This is progression. This is a case profile of a 64-year-old gentleman who had angle closure and had undergone a laser iridotomy. In 2001, this is what the optic disc looked like. By 2016, there was a small disc hemorrhage which was present in the inferior part. And this was something that both the HRT picked up on the trend and the event analysis, but showed no deterioration. Same thing happened with the octopus eye suit perimetry. The trend analysis showed no deterioration. So this patient with an angle closure who had developed a disc hemorrhage in 2016, despite structural and functional imaging being stable, had actually progressed. This is again a case example of a patient we first saw in 2009. Didn't have pictures of this patient, but I have this clinical diagram where you can actually see the inferior notch with nerve fiber layer change. By 2011, there was a nerve fiber layer change and a superadded disc hemorrhage, which got absorbed, and there was a diffused nerve fiber layer change in 2016. Surprisingly, the HRT showed a bifid nerve fiber layer change, a hemorrhage in 2011, which then coalesced to become a generalized reduction in the nerve fiber layer change. The trend analysis continued to be stable. So this patient who had progressed from 2009, 11, and 16, structural and functional imaging showed no change over time. So remember that comparisons with different instruments for imaging, the HRT, the OCT, and the GDX, have all been done to detect glaucoma, but none to assess progression over time. Another concern is that results from different instruments cannot be used to assess change. It's important to use the same instrument. And hardware and software changes are constantly happening. Results from older equipment cannot be used to assess change. Now, OCT software does not compensate for age. So if we see a change which is statistically significant slope as far as progression is concerned, remember that it need not be true progression. There are no defined or accepted criteria for structural progression on the OCT. Now, while there are three groups of parameters that are used, the peripapillary retinal nerve fiber layer is the one which is most commonly used, but evidence does not point to the superiority of one over the other. It is generally accepted that multiple tests need to be done to establish progression, but there is no evidence on the frequency and number of tests required. It's always good to have a baseline over a year and then perform at least one OCT per year. Functional progression is detected with white on white perimetry, and it can manifest as a new defect in an area which was previously normal, or there could be deepening of a pre-existing scotoma, or there could be an expansion of a pre-existing scotoma, or suddenly the entire field could develop a reduction in sensitivity. Widely used and validated is the Humphrey field analyzer and the octopus perimeter. It's always good that if you're a Humphrey user to use a central 30-degree or a 24-degree field. For Octopus users, it's a program 32 or a G1 program. For patients with advanced glaucoma, please use a Humphrey macular program or a 10-2 program. Octopus users can use a 12-degree program. It's always good on the Humphrey to use the CETA standard, and on the Octopus, use either the dynamic or the top strategy. This is a case profile of a 56-year-old who first came in 2003. And then again, at that time, he was not able to see a part of the Snellens with his right eye. This gentleman had an advanced glaucoma and extensive damage with sparing of fixation in both eyes on visual fields. Now, when the trend analysis were done, the focal defects were stable, but there was a depression in the mean defect and the diffuse defect, both the eyes, because of an increasing cataract. While the trend analysis on the HRT, both the eyes was stable. So this is how I would profile this patient. 2001, he was diagnosed to have glaucoma. He was on treatment with 4 drugs. Visual fields were done on pilocarpine. There was progression, but when the fields were done with dilatation, there was no change on the visual fields. In 2007, he visited the United States, where he was told that his vision will go away in 3 years. That's the time when he started having visual discomfort in his right eye. Multiple opinions were taken, and then he felt better. In 2011, he had visual discomfort because of an increasing cataract. He was given surgical options, but preferred only cataract surgery, which was done first in the right eye and 2 days later in the left eye. 2013, he had 2 falls because of poor vision in the left eye, but straight vision was 6/6, and radiological imaging and carotid Dopplers were normal. He was reassured. And then again in 2016, he had visual discomfort. He became stable with repeated consultations, but then visited the United States, where he was advised a surgery. At that time, Dinals had revealed a maximum pressure of 11 and 12. He was advised surgery. Patient was willing, but then surgery was refused. He came back, and because he belonged to the armed forces, the ophthalmologists were involved in the decision making, and a combined decision was taken not to operate. A Dynal was done, which revealed a rise in intraocular pressure at 4 o'clock in the morning. So his treatment was modified from brimonidine twice a day to thrice a day, and repeated Dynals were done, where we found that this earlier rise in intraocular pressure was blunted. The frequency of testing for visual fields is dependent on the severity of the disease. It's always good to form a baseline, and for patients with early glaucoma, 2 visual fields over a year are good enough, while patients from moderate to advanced glaucoma can get a baseline over 3 to 6 months' time. And subsequent monitoring can again be based on the severity. Early glaucoma can be monitored on a yearly basis, while moderate to advanced glaucoma from 3 to 6 months' time. Now, it's important to remember that you can't compare a visual fields done with the Humphrey parameter with an Octopus machine. You can't compare visual fields done on different Humphrey machines. Likewise, you can't compare visual fields done on different Octopus machines. It's always good to have a good baseline visual field, which is actually a reliable field with no more than a minor fluctuation in the mean deviation. And the learning curve needs to be kept in mind. We can't compare a 60-degree field with a 30-degree field. We should not compare a CETA fast fields with a CETA standard fields. We should not compare fields done with a stimulus size 5 with a stimulus size 3. So more importantly, we must use the same program, the same strategy, the same stimulus size, and use the software for analysis. Software allows us to assess it as an event analysis, for example, the GPA of the Humphrey visual field, or we can assess the trend that gives us the rate of progression by looking at the linear regression applied to global indices. The rate of progression is important because it tells us that patients who are progressing faster would need to be treated aggressively. This is again the case profile of another patient with angle closure glaucoma who underwent a laser iridotomy in 2003 and was on regular follow-up since then. In 2015, in August, when the fields were done and the trend analysis was looked at, in the right eye, there was a small change, deterioration in the right eye mean defect and the diffuse defect, but this was not statistically significant. In the same year, the patient came back in December of 2015 complaining of recurring blurring of vision. We repeated the fields and there was a bitemporal defect in both the eyes. So he was advised radiological imaging for the brain, which revealed a large pituitary tumor, which was then surgically operated. Following surgery in the right eye, the visual fields improved, and this change was statistically significant. So this glaucoma patient went on to develop a new neurological disease. So as life expectancy is on the increase, glaucoma patients are living longer. We need to keep in mind neurological lesions and other age-related macular lesions. So since blindness from glaucoma is not uncommon, we as clinicians need to worry about glaucoma progression. Success is in the follow-up, but remember that in India, most patients pay for it themselves. It's an out-of-pocket expense. Advise them some tests and they will invariably say, why do we need to get it done, doc? I got it done only last year. Do we actually need to repeat them again? So progression can be identified by functional and structural changes. It can also be identified by the test that we use to diagnose and by talking to the patient. At this stage, I'd also like to acknowledge my mentors, Dr. R. Ramakrishna and Dr. R. Krishnadas from the Arvind Eye Hospital, Dr. G. Chandrasekhar, Dr. A.K. Mandal and Santosh Honavar from the LV Prasad, and also Dr. Rao for the constant advice and encouragement that I have received from him over the years, and being a mentor all the way through, and to Professor N. Sood, not just because he's my father, but also because repeatedly he's emphasized to me that as clinicians, we need to remember that to manage the patient, that we must manage the patient as a person, not as an MRD number, not as an IOP level or an optic disc appearance or a printout of the visual fields, OCT or HRT. Thank you very much, GSI, for this opportunity. I'm grateful. Thank you.
Thank you. Thank you so much, Devin, for a wonderful talk. And I think you have precisely told so many areas where we have to concentrate on progression. It is not only on the visual fields or disc changes. There's quite a lot of things that we need to remember. Before we have our discussion done, we would like to have our the wonderful past president, our beloved Dr. B.K. Nayak, sir. Before he gives his talk, I would like to request our secretary, Dr. Manish, to... Dr. Manish, you are there?
Yes, I'm here.
Yeah. Manish, over to you to introduce our Dr. B.K. Nayak, sir.
So thank you very much for the opportunity to introduce a stalwart of ophthalmology of our times in our country, Dr. B.K. Nayak. He has been the leading light of glaucoma in Mumbai. He was the one who introduced, gave a lot of talks in perimetry when I was a student. So Dr. Sir has been a teacher, mentor, and a guide all through. He is the head of department and consultant at the PD Hinduja National Hospital in Mumbai, and he has held numerous posts, starting with the presidency of the BOA and the Maharashtra Ophthalmic, and the editor of the Journal of the Indian AIOS Journal, IJO. He has been past secretary of the AIOS, and president of the AIOS, and of course the president of the Glaucoma Society of India. He has been a speaker at many forums and given quite a few talks of interesting inputs, and I'm very much looking forward to his talk today, which will be, I'm sure, an eye-opener to many. Sir, please, Dr. B.K. Nayak, sir.
Yeah, thank you, Dr. Manish. First of all, I thank Dr. Satyan and Glaucoma Society of India for giving this opportunity. And it's nice that, can I share my screen?
Yes, sir, please.
Yeah, so okay, so now I'll just first share my screen. What is happening?
The bottom right, sir. The bottom right here.
No, just...
So next, yeah. Yes, sir.
Yeah. Yes, so now you can see the full screen.
Yes, yes, yes. We can see, sir.
Okay, so I'm thankful to GSI and Dr. Satyan for giving me this opportunity, or Dr. Manish for introducing me. Really, I get quite impressed whenever anyone really introduces me, and I always tell them, just make one line, that is more than sufficient for me. Anyway, so now coming to the topic, this topic seems to be a little, I think, different, but the statement apparently disregarded yet having a huge impact describes situations where something that is seemingly insignificant or overlooked can have a profound and lasting effect. This concept highlights the importance of considering all factors, even those that appear unimportant, as they can collectively influence the outcome. As you all know, that glaucoma is a chronic disease. Majority, because why I'm highlighting these points, because on this light of these points, probably some of the discussion you can interpret. Majority are asymptomatic. It needs lifelong management. Difficult for patient to realize the benefit of treatment. It can be controlled but cannot be cured. It may lead to blindness even with treatment. Just now, Dr. Devin also gave some figure. Patients are often frightened by the diagnosis. Merely giving a diagnosis of glaucoma influences his or her quality of life negatively, and estimated to account for 13% of new and 23% of follow-up appointment to hospital patients' clinic. So basically, it is important part of our workload. Now, what points I'm going to be discussing under this heading, because this topic is such that on this I can talk even for a whole day. But today I will be touching some of the points like initiation of treatment, prescription writing, diagnosis confused with neuro cases, underdiagnosis, and overtreatment. The initiation of treatment, first of all, establish the diagnosis, because I have seen many times without establishing proper diagnosis, patient comes for second opinion and they just simply said that doctor has started. I just went for my eye checkup and they said you have glaucoma and started. Any investigations done? No. Intraocular pressure only on non-contact tonometer. So these things is probably not the right approach to start treatment for a glaucoma, which patient needs lifelong treatment and affects quality of life just by diagnosis, telling diagnosis that you have got glaucoma. So establish diagnosis based on the intraocular pressure, disc, field of vision, gonioscopy, OCT. Not any one parameter can fix up the diagnosis. So it has to be the composite correlation of all the findings. Then you come to a diagnosis. And just now, Dr. Sood very nicely said about the progression. So glaucoma itself is a progressive optic neuropathy and by definition. So sometimes if you are in doubt, probably you can definitely, and because you have got certain equipments these days where you can measure the small changes taking place, which is more than the test-retest variability. So with that, you can have some, especially with pre-perimetric glaucoma, because these are what I have seen, patient done OCT, just showing one area or something red, the patients have straight away started treatment. So this and other things are normal. That's why pre-perimetric glaucoma. But I feel it is not the right approach. If the patient's other risk factors are there, then one can consider. But otherwise, this is not the right approach. So you have to have some amount of progression to establish the diagnosis, especially at this stage, because glaucoma is not a malignant disease in majority. So it will not lead to blindness if you delay by 6 months or 3 months of treatment in that stage, at that stage. Now progression, just now you heard on not only on perimetry, but on many parameters. So you have to have first baseline before starting treatment. Like, so establish the baseline properly, intraocular pressure, disc photograph for disc changes, perimetry, OCT, and gonioscopy. But also remember that all these parameters that you will be regularly following it up, it has different purpose to serve. Intraocular pressure basically will give you the idea that whatever treatment you have started, whether it is medical treatment, laser treatment, or surgical treatment, it is supposed to produce reduction in intraocular pressure. So how much reduction it has caused, that will be judged only by intraocular pressure. But other parameters, but that is not sufficient whether I have reached my final goal or not. So how will you judge that? On the other parameters, by judging the progression in future, like this photoperimetry, OCT, gonioscopy, and so nicely Dr. Sood just now elaborated all these points. So all those the baseline parameters must be established before starting treatment. And intraocular pressure is on first day. I basically never start treatment on the first day because if I delay by a week or 10 days, the patient is not going to go blind and not going to get worse. Always start low and gradually build up. Because again, based on the whatever we see, at some places when the patient comes for second or third opinion, that just patient was seen, one parameter intraocular pressure 25, maybe on non-contact tonometer, nothing else done, and started on 2 or 3 medication. Everyone else, means all of you can judge whether this is the right approach or not. And this treatment algorithm, because I always follow this treatment algorithm, which is not my algorithm, it is from the European Glaucoma Society, that start with monotherapy first. If it is effective and reach target IOP, then just continue. If it is effective, not reach the target pressure, then you have got 2 options, either change this or add something. And if it is not effective, means the effective you will judge by intraocular pressure, then there is no point even continuing this medicine or adding any medicine to this. So change this medicine and again follow the same. So till the time you reached where you attain a target that not progressing on your whatever parameter just now you have heard. So this is again important, because don't start with 2 medicines or 3 medicines right in the first go. Now patients, you are prescribing medicine or drug, but it will produce effect only if the patient takes it. Now, you will be surprised if you find out how many patients are really compliant about the treatment and they are taking regularly as per your advice. You will be surprised that it's not a very high percentage that they comply with this. Now, why? Because the patient has got some idea, because there is a balance between the idea and experience. Idea is only what? Understanding the potential risk of glaucoma, which is very difficult to understand by a patient who doesn't have any symptom. Then their belief in the benefit of medication, because it is again just a belief that, okay, you keep this medicine, use it regularly, your pressure will be down. And when they come to doctor, they say, oh, very nice, I'm very happy, it is all well controlled. But patient says, I don't see any difference. So it's just the idea that it has to get engraved in their mind. And then the balance between experience. Now here, the experience is negative for the patient to continue, which is the burden of taking their drops, inconvenience, lifestyle change, cost, and unique nuisance of side effects. To overcome this, you have to communicate properly, which probably most of us in busy schedule don't spend much time with the patient. So spend enough table time with the patient on every visit, not just first or second visit, every visit. And also try to watch intelligently about the compliance. If you just simply ask them, are you putting medicine regularly? They will say yes. Most of the patients will say yes, because they don't want to be bad patients. So they will say yes. But there are various ways. Intelligently, you have to find out that what is the compliance in this particular patients. So that spending table time with the patient is important. And apart from about the disease process, about the treatment benefit and all those, not that once you explain, then that is enough. Means you keep on regular intervals explaining to the patient. And also, many times patients ask, doctor, what precautions should I take? Now, some patients who are really very concerned, they will ask you, doctor, what precautions should I take? Now, there are many points which I have enumerated here. So you can, not that everything you have to tell them or discuss with the patients and just in first go, but means every time at least you have some points to discuss the same point or sometimes repeat discussions. So these are like, but the first two are very important. Take medicines regularly, follow up regularly. These two things must be emphasized on every visit. Then eat well, balanced diet, quit smoking if they smoke, take care of chronic cough and constipation, because every time they do that, there is a rise in pressure which has cumulative effect. Avoid drinking a large quantity of water at one go in India, which is means many patients do that early in the morning, 4 or 5 glasses of water, and they don't know what is the result. Means we also don't realize that, we don't ask them. Then control diabetes and hypertension. Steroid in any form must be informed to the doctor. Snoring and OSA, if the patients are not well controlled and still means control or progressing, then you find out these history from the patients. Avoid Valsalva or wind musical instrument if you can. And yoga, exercise, these things are important. They should do it, but in moderation. And yoga and exercise, remember, tell patients not to bend so much that the head level or the eye level is below the heart position. So that position should be avoided. And there's a very nice study done by Dr. Tanuj Dada that about the breathing technique. So 3-6-5 breathing, especially in the end stage disease. Now I have started describing or explaining to all patients that do this because this is simple to do it, and that stage they do it regularly. Sometimes other patients who also feel that, okay, now if I feel that they are very much concerned, then I tell them to do that and they do that. Prescription writing, because this type of prescription is only for glaucoma. Remember, the patient is old age, must be having many comorbidity. So patients is not only for eye treatment, for other treatments. So if you are prescribing like this, I'll come back to this prescription later. So the basic thing is that be simple and do not complicate. Yeah. And I always follow the advice of my teacher, Professor L.P. Agrawal. No medication is best medication and least medication is the best alternative. And above all, do no harm, because more medications, more side effects, more harm. So if it is needed, definitely do that. So you have to take a balanced view. Now, some of the prescription, just 2 or 3 examples, that it's one of the prescription written just simply iodine 0.5% ED, both eyes at night. Now, in this, the abbreviations are used. Patient will not know what is this ED means. Wrong timing, because if iodine beta blocker has to be used once, then it should not be used at night. Incomplete instruction is not given full, and the follow-up instructions not given. Only thing, if they would have written iodine 0.5% eye drops, 1 drop in each eye in the morning, and follow up after 4 weeks. So at least you have given the follow-up instructions also. And one thing which I have also started telling them now, because most of the patients, when they come for follow-up, have you used the medicine today? No, sir, because I was coming to you. So I thought you must examine without medication. On the contrary, you want with medication. So that instruction also should be given on day of visit. They must use their normal dose. Now, Xalatan eye drops, 1 drop in each eye twice daily. Again, this is not the correct dose, because as a contrary, there is a paradoxical response published literature where the effect becomes less. So wrong dosing. And this prescription is again this kind of prescription, because now the multiple companies coming forward with multiple name, their brand name and combination. So Combigan and Travacom. Now in this, the beta blocker is common. So you are not, both the medicines are not causing its full beneficial effect, rather than causing more damage and side effects. And also see, the first medicine is refresh tears. So patients sometimes feel, oh, doctor, 3 likha, I will use only 2. So they will discard the third one. So probably the important medicines you must emphasize and write first, then the unimportant means the less important medicine. Now come back to this prescription again. Now this you see the first capsule Lacregard, and the last four Cystine, Irivix, Refresh Tears, and Lacri EPF eye ointment. Now, what does the doctor want? Does he want to satisfy all the pharmaceutical companies? And then also see Lumigan, left eye, bedtime, and Zolatan once in the morning, same left eye. Now this one, again, the same group of medicine, and you are putting one in the morning, one in the evening. So this kind of complex and the wrong prescription one should avoid. And I'm really not surprised if I don't get every day at least one such prescription, whatever examples I have given. So please guide everyone and tell them that not to do that, and take care in that aspect, because that is something patient is again using lifelong treatment. Combine different drug with different mode of action if there are two medicines you are giving. But the third medicine, then you don't have option, because there are only mainly two mode of action, either reduces the secretion or enhances the outflow facility. And again, European Glaucoma Society guidelines, it is unlikely that more than 2 pharmaceutical preparations with maximum 3 active molecules going to be effective, additive, well tolerated, and reliably taken by the patient. So fortunately, these days, the combination drops are there. So at least the number of drops can be reduced. So the side effects as well as the compliance becomes better. Now, again, Dr. Sood touched upon this point, but this again, we ophthalmologists, we feel that patient has come to me glaucoma and I'm treating glaucoma, so patient can have nothing else but glaucoma and always glaucoma. So it can be associated with glaucoma, or patient may not be having glaucoma, but may be actually neuro-ophthalmological case. So typically glaucoma is symptom-wise painless and asymptomatic. Signs, normal visual acuity, unless it's a very advanced stage of disease. So if the normal visual acuity is not there, you should be able to explain why it is not there. The typical nerve fiber layer defect and glaucomatous cupping with glaucomatous cupping and slow visual field loss. So these, if something which is bypassing this, like loss of central visual acuity, which you cannot explain, cup to field mismatch, hemianopic visual field loss, rapid progression, pallor more than cupping, and some shunt vessels retinochoroidal on this, then you should be careful. Now just remember that glaucoma field defects arises from the from the retina. Now in the retina, the distribution of nerve fibers are such that it never crosses the horizontal rapid. Therefore, the defect in the upper part, and so there is a separation and nasal step formation in glaucoma. So it never crosses. Whereas in the neurological, if it is in the chiasma and beyond, there will be vertical separation from the fixation point. So these two factors you must remember. Now this example is nothing great about it, no brainer required. It's a bitemporal hemianopic defect, left eye and the right eye. And the disc also is not the glaucomatous optic copy or atrophy. It is the bow tie type of optic atrophy, which is nasal and temporal, not superior or inferior, which is hallmark of glaucoma. And this was the diagnosis. So there's nothing great about it. But why I'm presenting this was the field 2 years before. Now here, the right eye, again, hemianopic defect, temporal. Left eye, some points missing on the temporal side. This time also the doctor should have been careful and should have thought of neuro-ophthalmological cases. Now, this was 2 years prior to that. The left eye was absolutely normal, but the right eye, again, the defects were localized only to the vertical meridian on the temporal side. So this is the stage when we should pick up. Then we are doing justice. So whenever you are analyzing the perimetry, then by all those 1, 2, 3, 4, finally, earlier I used to tell that there's no need to look at the actual threshold values. But now, if the seemingly everything is normal, still before you say it is absolutely normal, you must look at the threshold value, the value on this. So because hemianopic defect, early hemianopic defect, anything which is behind in the chiasma or behind, then it will produce hemianopic defect. So early defect can be appreciated by analyzing the points adjacent to vertical meridian. Now the RP Mill has given, just like Anderson's criteria for early glaucomatous field defect, similarly RP Mill's criteria, where in this field, if you see, the otherwise is nothing very significant. But if you look at the figures on the right hand corner, the actual threshold value, then on the adjacent, on the vertical meridian, the 3 adjacent points, means along both the sides, pair points, you will start seeing if the difference is unidirectional, at least 2 decibel difference, then you move to the next row. And there also, if it is same thing, next column, if it is the same difference on the same side, then probably, even if it is not looking that typical hemianopic defect, you may be dealing with the early hemianopic defect, as in this case, which was the pituitary. Now I'll read the RP Mills criteria so that you can remember. Each threshold value on one side should be compared with corresponding value on the other side of the vertical meridian. Adjacent row first. At least 3 adjacent pairs along the midline should show a unidirectional difference in sensitivity. Then move on to the next column of values, and at least 2 decibel difference is significant. And now another example, this case was diagnosed advanced glaucoma, only based on the intraocular pressure recorded as 20 and 22, between that. And no perimetry was done. GDX VCC was done, and this was the optic disc, definitely suggestive of glaucoma. The other one, again, little better, but still suggestive of glaucoma. And the GDX, which that time was very popular, but now it has become instinct. So all parameters were suggestive of glaucoma. But what was missing? Perimetry was not done. So that's an abnormal GDX, or for that matter, only on OCT or HRT, that is also now getting in the instinct gradually. So can we diagnose glaucoma only on that without doing perimetry? This was the perimetry. So this is a clear case. It is not a case of glaucoma at all. The straight away should have gone to the neurologist or neurosurgeons. And so red flags, just remember those red flags and take care of that, so that at least you will be not doing wrong treatment. Now, underdiagnosis is also common because 50% of glaucoma patients in community remain undiagnosed worldwide, and in India, this figure is more than 90%. Now, patients, why it is so? Because patients not presenting to eye clinic. We also don't examine properly, because Chennai Glaucoma Survey, 50% newly diagnosed checkup had previous eye checkup in previous year. So all 50% would not have developed glaucoma just in last 1 year. 40% of open angle glaucoma had angle closure glaucoma, means gonioscopy was not done. So need comprehensive eye examination and as well as the public awareness. Now, over-treatment also is a reality. 50% of glaucoma patients either do not need treatment or are being over-treated. This is a published literature. Now, how does it affect? Higher cost affects quality of life, risk of side effects, and high percentage of non-compliance. More the drops, lesser is the compliance. And why it is so? Because improper workup, lack of infrastructure, fear of blindness, multiple drugs with no disc and field changes, which is a common prescription, which I see very often, using only tonometer for basis of treatment. Then again, this line is important. Overestimation of benefit of therapy and underestimation of associated risk of therapy. So this probably we have to realize, and never a newer molecule and hard selling by medical representative. So please remember these facts. And but under treatment also is a reality, especially in advanced glaucoma where surgery should be done. But usually, patients sometimes 4 drugs, 5 drugs, they are pushed on, and the fields are very narrow. But just because of central wipeout phenomena, they avoid surgery. Means the doctors don't, because they don't even suggest surgery, and patients also get scared. So please take care of that. So I think if these points, whatever little in 20 minutes I have explained, probably this will give some help in the comprehensive ophthalmologist, not the glaucoma especially, the comprehensive ophthalmologist taking better care of the glaucoma patients. Thank you.
Thank you so much, sir. I would sincerely thank both of you for your wonderful talks, Dr. Deven and Dr. B.K. Nayak, sir, for not only a good talk, but more of a very practical talk for today's glaucoma practice. It is just not enough for you or for all of us just to treat the intraocular pressure in the glaucoma. So we have Dr. Devetuli, we have our secretary, Dr. Manish, and we have Dr. Devindra Sood and Dr. B.K. Nayak, sir. So we'll have probably for next 10 minutes or so, we can have some small discussion. Manish, do you have some specific questions for our audience so that?
So I would like to direct my first question to Devin. He talked about progression beautifully and the various aspects of progression. When we talk of progression, as he explained very well, it does not mean only the OCT and the visual field, but it means many more things. But I would like to ask him that, he has very clearly made out in his talk that the progression, when we are looking at an established glaucoma patient who is on therapy, we are seeing the visual field and using the software, which we use the GPA, as he pointed out. As far as the OCT is concerned, we are using the software because there is no other way of knowing. We are using the software for progression evaluation. So can you throw some light about how the OCT progression is to be looked at? Of course, we look at both, everything together, the clinical picture as well as the visual field and OCT. But then we have cases where the visual field seems to be holding quite well. Pressures are within target every time, no obvious signs seen, but the OCT progression keeps lighting up on second 2 or 3 follow-ups. So what would be his take on that?
So, Manish, I think that's a very good question. And at times, we get carried away by technology, especially if particularly the OCT is showing a change. I think the important thing to remember is that progression can be structural and functional, in addition to the other aspects that I mentioned. And both the visual fields and the structural imaging can show a change either independently or together. Now, there is no need for a consensus between structural and functional progression. They measure different things with different technologies. The principle is different. So if the fields change over a period of time, it is progression. If the OCT changes over a period of time, you need to consider progression, but keep in mind that progression on OCT alone is not my criteria to say progression, because there are certain aspects, as I mentioned, the age-related change doesn't come into play with the OCT. So just because there's a deterioration in the slope does not necessarily mean that it is progression. Again, to emphasize, it is progression, not blindness that is happening. Second thing is the rate of change of progression is very important, which is where the visual fields will actually help you. A rate of change of progression up to 1 decibels, anything more than 1 decibel is significant. More than 2 decibels is dastardly, actually. So that's where you would be extremely aggressive in terms of your treatment. So coming back, progression on OCT alone is a red flag for me. I would not be depending on it entirely.
Okay, that's nice, Devan. So I'll just put you, all of you, into one controversial statement I'm going to make now is, in reality, I'm not specifying any particular doctor. Many people tend to treat the glaucoma just based on only on the IOP. And most of them treat like the progression is based on the IOP. I'm just putting you into only a controversial statement now. So once the IOP is below 20, the medications have been asked to continue. If it is above 20, either you add a medication or you go for another mode of treatment. How would you put this into the reality practice?
So what I think is coming out is that there is a change in the intraocular pressure from baseline. So
Yeah.
how was the intraocular pressure measured? What was the instrument used? And what was the range of increase in intraocular pressure. Because remember that there has to be a certain intra-test variability that will happen when intraocular pressure is being measured. It's higher with instruments like non-contact, tonopen, or even the rebound tonometer.
Devan, I'll just refine my thing. IOP was 26. Now the IOP is 18. Does that mean the patient is completely under control? That is, most of the time, if the IOP is under control, many of the places it is just been asked to continue the medications to control glaucoma.
So
If it is
it's
about
not
20, it is about 20. The reason why I'm asking is not everybody has the visual fields done, was CT done, or the fundus examination done properly. So I'm talking about kind of a reality practice in majority of the places. That's why I'm asking this question, because it is quite relevant in many of the scenarios.
So, Satyan, I think the examination for diagnosis of glaucoma should not be compromised. Problems usually happen when you miss something or don't do something. So, if you base your diagnosis on intraocular pressure alone, then you're likely to run into a problem. So, how low you want to get the intraocular pressure in a proven case of glaucoma is dependent on the severity of the damage. More the damage, lower the intraocular pressure. So, the example as you gave, 26 may be a good pressure. You may say that the damage may have happened at a higher pressure, so 18 should be all right. But if the patient has a total cupping, then you'd like pressures closer to 10 and 12. So then 18 would not be an acceptable pressure. If the patient has an ocular hypertension, the discs were normal, then perhaps 18 would be an acceptable pressure as a snapshot pressure. But remember that the intraocular pressure is not a static entity, it will fluctuate. So when you say, I'm happy with this pressure, Dianel should have ruled out a fluctuation in intraocular pressure.
Yeah, that's what I wanted to just drive you to that level, because just bringing down the intraocular pressure to the normal range doesn't mean that the patient is not going to progress. So that is a kind of misunderstanding in many people, that you just bring down the intraocular pressures to the normal range, then everything is fine. So it is not so. So
Now,
so
can I just come for a second?
yes, sir. Yes, sir. Please.
Yeah, actually, this means earlier, I will say it's about 15 years back. Definitely, the 20 was supposed to be a cutoff, 20 or 25 years back. So less than 20 people used to be happy, more than 20, then it's bring it down. But
Correct.
now it has what the Dr. Devin just now said, that many factors are is contribute that how much should be the target pressure. And especially as the advanced glaucoma, as he pointed out, definitely lower pressure. And all patients are not equally susceptible to the same level of pressure, their optic nerve. So based on that, so there cannot be any single cutoff point for well-controlled and not controlled glaucoma. So this everyone should understand and realize.
Absolutely, sir. Dr. Devin Tuli, you are there? Okay. Devin seems to be probably gone for the other one. Okay. So we have another couple of minutes to go. Nayak sir, you want to say something, or Devin, you want to say something? Specifics, so that there is
One thing I
message
want to
for
say
the audience.
Yeah, one thing specific I want to say about the use of OCT, because one should remember that doing OCT once on this machine, the second time on different machine, third time on different location, that is not the proper way of doing OCT, number one. Number two, the OCT should always be done on the same place, same machine. And the machine, if the machine has got the registration and centration, where every time it does the recording or the photographing and the measurement at the same location, it means, in other words, the retest variability is very, very low. Then progression, and the progression is more than that retest variability, then probably that instrument is the good instrument, and that the basic principle we should follow. So that is something OCT, I always say one statement, that it is probably one of the most abused machine in ophthalmology as related to, as in relation to glaucoma.
Thank you, sir. Thank you, Dr. Devin and BK Nayak sir, for your wonderful talks from both of you. I'm sure that all our audience, whether they are on live today, they have taken all the points. And if some of them have really missed today's talk, they can go to our website and see all our videos. Thank you so much once again, and we will see you next week in our General Club meeting. Thank you once again to all of you.
Thank you. Thank you very much. Very
Thank
well.
you, thank you, and
Thank
good
you,
night.
everyone.
Thank you,
Thank
sir.
you very much.
Thank
And
you.
good night to everyone.
Good
Good
night,
night.
sir.
Thank you.
Good
Thank
night.
you.
Thank you, Satyan. Thank you.